Yeah, hi everyone. So this is Daneshmand from USC in Los Angeles, California. So the question, we presented two abstracts here. One was the BOND-3 study, cohort P. This is a new study, a new cohort basically, for patients with BCG unresponsive papillary disease. And the other study was Pivot 006. Your question is, what is the molecular mechanism of cretostimogene grenadenorepvec? This is a conditionally replicating adenovirus that binds the Coxsackie adenovirus receptor on the bladder cancer cells, which most of them have this receptor. It encodes the GM-CSF gene, and it works through the RBE2F1 pathway. So basically, once it gets in, it's an oncolytic virus. It does replicate and conditionally will replicate within these cells, leading to cell death. That will in turn produce the antigens for the immune cells to come in and produce the secondary effect of this drug. So you have the oncolytic effect and the immune response after that. So it's a dual mechanism of action. It's highly effective, and it's been shown in previous trials to be highly effective for high-grade BCG unresponsive disease. So in this trial, for the BOND-3 study, cohort P, we're targeting patients who have papillary-only disease, so no CIS. The previous studies had been done in CIS with or without papillary disease. This is just with papillary disease. Yeah, so again, the BOND-003 trial has been ongoing for a long time, and we know a lot about the safety of this new therapy for bladder cancer. It is very well tolerated. There are essentially no grade 3 or 4 side effects. Most of them are the usual bladder irritative voiding symptoms and dysuria frequency that we often see with any intravesical therapy. So the good news is we're not seeing major side effects. It's very well tolerated. This has been shown in previous trials. There's an ongoing trial called Pivot 6 or Pivot 006 that is for intermediate risk patients. This is the AUA definition of intermediate risk patients that includes the low-grade papillary disease that is either recurrent, large tumors greater than 3 centimeters, or small high-grade Ta tumors as defined by the AUA risk categorization. So again, it's a very well-tolerated drug regimen we've known from previous trials, and of course we'll learn and gain additional experience with these ongoing trials. Yes, that's the issue right now. The problem is we don't have any molecular markers that are reliably will tell us who will respond and who doesn't respond. I think that's what we need to do more of in the future. For now, we know that these receptors are present in most bladder cancer cells, and so we have efficacy across the board, but we haven't really honed down on molecular markers that will help us differentiate whether this treatment or another treatment would work better for the patients. This will have implications on sequencing in the future of these drugs and which patients are appropriate candidates for any one therapy. Well, yeah, I think there's a lot more to be learned. We want to know its efficacy in low-grade disease. That's what Pivot 6 is targeting. We want to know mechanisms of resistance in this population. I think the safety part will gain additional data, obviously, but there's a lot of urine studies and being done to see if we can predict the efficacy, predict the response. So there's a lot of corollary studies planned with these trials that are ongoing that will hopefully shed light on the future management of the disease.